Well, we've got a good number here. I think we should, in the interest of time, I think we should start. I'm Leslie Krumholtz, the co-founder and CEO of Hugo Health Kindred, but I am passing this over to Talia, who is our wonderful content and community manager, who many of you have had some contact with or certainly hear from her weekly. So with that, Talia, I'm going to pass this out all over to you, and we'll get going. We're so happy that everyone's here.
Hey everyone, I'm so happy that you all could make it. Super excited about today's cafe. We are pleased and honored to be hosting Dr. David Putrino this afternoon and to have so many people in attendance. I'm Talia Roches again, and I am the content and community manager at Hugo Health Kindred. For those of you that don't know, Kindred is building a network of data-enabled people who have been impacted by COVID and who want to contribute to research in partnership with leading scientists. I strongly encourage anyone who is not yet a member to join us. You can go to kindred.hugo.health for more information, and it is from Kindred that you can enroll in the Yale Listen Study led by Drs. Iwasaki and Krumholtz. And without further ado, I will pass it off to our wonderful co-hosts. We have Cynthia Adenig, who is living with long COVID, and we have Nick Ferrara, who is living with vaccine injury. And we are super excited that they could join us today for this really important cafe.
Thanks for having us. I actually am a super fangirl of Dr. Putrino. He just doesn't know that because being from the first wave, before long COVID had a name, he was one of the first medical providers that fought for people like me who got long COVID but never got access to a test that proved that I had what started my illness. And it was the name that I would repeat everywhere at every hospital that I would go to when they didn't believe me and I was dying of starvation, and they were treating me as it was all psychosomatic or whatever. And it really, really gave us hope in those early days that someone understood and knew something else was going on. A professional really knew, and it's not just us normal people that are seeing this. And it really validated our symptoms and experience and struggles in those early days. But
my name's Nick. I'm here from a vaccine injury from early 2021. I took the Pfizer shot, and it gave me a neurological disease that ended up with small fiber neuropathy, damage to the large fibers, ulnar neuropathy, swelling hands, tremors, twitches, everything you could possibly think of. Really a horrible neurological disorder. So over the time of trying to figure out what has happened to me, I've gained a lot of traction in getting better. I've talked to a lot of people. I mean, a lot of people, probably thousands over time, who have had similar issues, people that were going through different testing and diagnostics. So I was able to do a lot of stuff, a lot of treatments. I tried a lot of things that didn't work, some stuff that did work, and I've made a lot of progress. So I'm here. I know a lot of people. I'm here to advocate for them as well, and kind of hopefully we can get this research going and figure out what has gone on. So in my specific situation, there was a lot of things that happened. The thing that I went after was small fiber and certain autoantibodies. I treated that. I did get better. My symptoms overlap a lot of other people with vaccine reactions and long COVID, but the same treatment doesn't seem to work for everybody. So it is very strange, quite a mystery to a lot of it, but that's why I'm here, is to kind of shed some light on some stuff and what I've done that's helped me. And I've really gone from seeming like I wasn't going to be able to function at all to living a pretty normal life now. So that's why I'm here.
It's an absolute honor to be here, and I was so happy, Leslie, when you invited me to come on and hopefully answer some questions and share what I know. My name's David Putrino. I'm the Director of Rehab Innovation for the Mount Sinai Health System. My clinical background is as a physical therapist. My research background is that I have a PhD in neuroscience, and I've been studying how to help people who are living with all sorts of chronic neurological disabilities for a really long time. And my research has mainly always been focused on this one statistic that always bothers me, which is that on average, it takes new treatments around 17 years to make it from bench to bedside. which is a dumb statistic. It's something that shouldn't exist. It's something that really frustrates me in terms of just why the sort of mainstream medical agenda moves so slowly and moves in such an incremental way. And largely over the years, pre-COVID, some of the things that we've learned is really that most of the clinical trials that aim to help patients suffer from the same limitations. They don't engage in community co-design. They don't speak to people like Cynthia and Nick. They rely heavily on what's in textbooks and not on listening to lived experience. And then even if a clinical trial is successful, often it will just take years for the clinicians who are not researching clinicians to actually adopt what they're seeing. So I'm fortunate enough to run 4 centers, soon to be 5 at Mount Sinai, that are focused on rapid adoption of novel technologies that can help people. And so, you know, when COVID hit, I just felt that I was in the right place and time to initially help all of the people who were suffering from acute infection. But then as we started to see folks who were experiencing these lingering effects, we started to see folks who were experiencing vaccine injury. We were on hand to just do our best to help there as well. And you know, I feel I honestly feel a little bit of nervousness every time I talk to the community, because I feel like the community is learning at the rate that we're learning, you know, so I'm always just hoping that I can contribute something. But often the best conversations that I'm having are with people from the patient-led communities who are researching and reading, you know, at a rate that is the same, if not greater, as me. And, you know, that's where good ideas are coming from.
Talia, do you want to sort of lay out how this is going to work?
Sure. So first, everyone, we're going to answer the questions that those who submitted them previously sent me, and then we will go through some live Q&A with whatever questions you have now. So if you have any questions, you can put those in the Q&A, and we will do our best to answer them during the hour-long event. So Cynthia, if you wanted to start with the questions that were submitted beforehand, we can get right into it.
Yes, I do see a question here from Michelle. It says, once testing microclotting becomes more scalable, is it possible to combine capturing data on microclotting, ABG and lactate and peak near peak exertion to see if more are also experiencing elevated lactic acidosis? This is a good question. And also QEEG, like WABI, to capture changes in the brain pre and post exertion to provide collection of data on individuals that are gathered at nearly the same time, or is that kind of combination too prohibitive to capture around exertion? That's a very good, very, very good question. I would love to hear what you have to say about that, Dr. Putrino, and I also have some comments on that as well, because that's something I've been thinking about, how it's possible to do with some of the things that we learned in 2022 about PM and other things that we're seeing that are capturing some things.
Yeah, and I think this is a great question to launch into that really highlights what I just said about so many of the community just being way, you know, like I wish I had a whole bunch of scientists thinking this way about long COVID and long COVID symptomatology. I absolutely think that there are, for the microclot research, there's 2 really important next steps. I mean, I think anyone who has a handle on the literature and doesn't have pre-existing biases will acknowledge that the work that's been done by Doug Curl and Riccia Pretorius and so many others is really convincing enough at this stage to say that microclots are a major mechanism in long COVID that are causing symptoms. And we're also seeing it in vaccine injured folks. We're also seeing it in folks with ME/CFS. So there's something going on with these hypercoagulable states in folks with with these complex chronic illnesses. The next step, well, there's a fork in the road. The first is exactly this sort of exploration. We need to understand how microclot load correlates with symptom burden in folks with these illnesses. I think initially we should start less granular because you know, a lot of things, for instance, QEEG was mentioned there, and it's really hard to predict what is going to cause a change in QEEG. It's a very personalized measure from my experience with QEEG, meaning that, oh, for the record, QEEG is quantitative EEG, and EEG is electroencephalography. So it is the measure of brain activity using an external device that kind of just sits on the head. Now, QEEG is very, very similar, in my opinion, to other metrics like heart rate variability, where you kind of need to know where someone starts at to know how a change in their QEEG will result in a change in function. So for me, the starting point that we want to get to is, let's look at global levels of function, global levels of symptom burden, to understand how microclot load, how many microclots you have in your system, is correlating with these global measures. Because let's also not forget that long COVID is so different in everybody that, you know, sometimes someone's QEEG may not correlate at all with their microclot burden because they don't really have any cognitive symptoms, but they have a lot of PEM, or they have a lot of pulmonary symptoms. And so starting off with just trying to understand how microclots are interacting with overall symptom burden, I think, is a really good start. We have some initial data, pilot data that we're hoping to publish soon that did show correlations between cognitive symptoms and other symptoms, simple symptoms like gait speed, how quickly someone could walk, and their microclot burden. I know for a fact that there are some groups in the UK that are also have some work under review showing a correlation between long COVID symptom burden and microclot load. So I think that this is the promising direction for the microclot research. We need to quantify what we're seeing in terms of microclots, which is a big part of the research going on in my lab right now, is how do we quantify what we're seeing, as opposed to, yes, you have microclots, or no, you don't. And then starting to correlate it with symptoms. So that's one direction. The other direction, of course, is we need to start to evaluate how specific targeted treatments that have been proposed for microclots are actually affecting microclot loads. So I think many people have probably heard about studies that are going on in South Africa right now for anticoagulation and antiplatelet therapies. I'm eagerly waiting for the results of those studies so that it can form a precedent for doing similar studies here in the United States. But what we really want to see is microclot burden before and microclot load afterwards, to see that the therapies are actually changing the distribution of microclots in the blood. And same for things like nattokinase and lumbrikinase and some of the supplements that people are trying. Show me that it's changing these things. I think that those are the two next frontiers that we need to work toward to start to cement microclot theory as something that really needs to be addressed in long COVID.
And my take on this, as I've been pondering this for a while, is, you know, what are we missing with the ME/CFS community, especially those who have myalgic encephalomyelitis, chronic fatigue syndrome from Epstein-Barr virus? Because when I talk to others in that community, a lot of their symptoms are the same, a lot of their flares are the same, and we know even with a large subset of us that we end up getting reactivated EBV upon long COVID. And there's a lot more information that we already have, that if we start looking at past information from patients to kind of weave together these puzzle pieces, we can get faster and better information concerning therapies and treatments and see what works and what doesn't.
Absolutely.
All right, we're ready for our next question. So we have a pre-submitted question, David, and he asks, any therapy for neuromuscular issues in the thighs for vaccine injury? Also, what to do about weight loss due to lack of appetite? I'm down 24 pounds so far.
Ooh. So, I mean, I would say that, I mean, the first thing that I would always sort of caution on is any big amounts of weight loss. Please make sure that you're seeing a doctor and getting a lot of things checked out, because 24 pounds is an enormous amount of weight to lose, and that may be related to other things going on in the body. So I hope that there is a good provider, a trusted provider who is running through a laundry list of tests to make sure that that where the weight loss is related, the weight loss and loss of appetite is related to the vaccine injury, and not something else. So please check things out. In terms of neuromuscular issues, I mean, there are a lot of different things that we've been doing for our long COVID and vaccine injured patients who are experiencing persistent chronic pain. Obviously, we don't want to go down the road of opioids, because that is, you know, not always productive and dangerous, and often causes more problems than it solves. We certainly have had some success with low dose neuropathic pain medications such as gabapentin, and that's often worth bringing up with your physician and seeing if that can be of use for neuromuscular issues and pain issues. And then, you know, there are other therapies that are available that are more cutting edge and emerging, but also easier to access and low cost. So there are some really great things like virtual reality therapy that we use on our patients for who are experiencing neuropathic pain and neuromuscular issues, that really help to reduce the level of pain that they're experiencing. Now, this is symptomatic relief, but again, you know, one of the things that I'm always advocating for is, I know that it's not great to hear that all we have right now is symptomatic treatments, but symptomatic treatments can keep you functional while we're working on the underlying causes. And so things like virtual reality, things like using TENS machines, things like using heat and cold exposure for muscle cramping and muscle pain. These are things that are worth committing to and working with, because they can really reduce the level of symptoms that are being experienced.
Great, awesome. And we have another pre-submitted question. Sorry, just one second. So Julie asked, when Dr. Putrino speaks about new information surrounding emerging interventions for symptoms of long COVID, could he note if that is felt? Could he note if it is felt that those with post-vaccine long haul could also benefit?
Yeah, this is a great question, and this is why Akiko and I are working really hard to integrate people with vaccine injury into all of our studies, so that we can look for similarities and differences between the two groups. I mean, I think, once again, you know, for anybody who is for anyone who is just reading all of the literature that is emerging without bias associated with their opinions, it should be pretty clear that both vaccine injury and long COVID are at the very least biosimilar. You know, it may not be the exact pathobiology going on, the exact things happening in the body of a person with long COVID and with vaccine injury, but it's something very, very similar. And certainly right now, as we start to dig into the literature, the idea that the immune system of folks with long COVID and folks with vaccine injury is leading a lot of other downstream issues, so this idea that perhaps that there is some level of viral persistence or spike protein persistence in folks with vaccine injury, the idea that latent autoimmunity has been unmasked, the idea that as a result of the immune system being so taxed by either the vaccine or viral persistence that we're starting to get latent virus reactivation that then goes on to lead to all sorts of tissue damage and dysfunction, that then goes on to lead to vascular damage, endotheliitis, microclot issues, hormone imbalances, mitochondrial dysfunction, et cetera, et cetera. I think that this cascade of issues is very linked between the two populations. We certainly need more research. I think that there are a lot of barriers to vaccine injury research right now, and we're working as fast as we can to knock those barriers down. One of the things that we face a lot of the time is, our protocols get criticized. How do you know this person has vaccine injury? What's your inclusion criteria for vaccine injury? And how do you know it's not long COVID? And we're kind of like, do we care? Can't we just say this person received a vaccine, they started to develop long COVID-like symptoms after the vaccine with no other evidence of infection? So yes, we will be open to the idea that they may have long COVID from an asymptomatic, perfectly timed COVID infection, sure, but we're going to call them, for the sake of brevity, vaccine injury, because that's really what it seems to be. But this is, just to be very transparent, this is the sort of pushback that we get when we try to put these protocols in for ethics approval and for funding. And so we have this group of vaccine injured folks. We're studying them, and we're hoping to be able to, in very short order, have a good faith, side-by-side comparison of long COVID and vaccine injury, and hopefully we'll be seeing very similar pathobiologies at play that then would make a good faith basis for the fact that similar treatments would apply.
Great, thank you so much. And next we have a question from Nicole, and Nicole asks, can you speak about your clinic and services provided? Most long-haul clinic require proof of positive COVID tests and will not treat vaccine injuries.
Yeah, so it's always frustrating to hear that. And again, full disclosure, full transparency. Cynthia was very kind to say that we were seeing people without a evidence of a COVID infection at the start, and that's true that our center was doing that. But it's also true that early in the pandemic, Mount Sinai policy, before we rethought things, that Mount Sinai policy was the same, that you had to have clear evidence that you had COVID. I'm happy to say that has changed, because in accordance with CDC clinical case definitions of long COVID, the CDC could not have been more clear that you do not need a positive COVID test to receive a diagnosis of long COVID. That you could have a presumed positive case, meaning, I was unwell, or even you weren't unwell, but you were exposed to COVID. You didn't get symptoms acutely, but you went on to develop symptoms all the same. For vaccine injury, I think that, we are certainly seeing acknowledgement of vaccine injury. We don't have an ICD-10 diagnosis code for it yet, but Mount Sinai, the Center for Post-COVID Care at Mount Sinai, has started to see folks with vaccine injury. In terms of what the, what our clinic looks like, we are physiatry-led. Physiatrists are rehab doctors. So we try to, we've tried to put rehab doctors at the forefront for two main reasons. The first is that from the outset of the COVID-19 pandemic, the American Association of Physical Medicine and Rehabilitation has really, more than other specialty groups, has really led the a lot of continuing education for other doctors about long COVID. So that's one reason. The second reason is, and there's a lot of great resources on the AAPMR website. The other reason is that rehab doctors are very used to dealing with highly complex illness. We're routinely here at Mount Sinai in the rehab department, routinely dealing with complex spinal cord injuries, traumatic brain injuries, severe concussion and post-concussion syndrome. And so we're very used to pulling in other specialties to help, as opposed to a lot of other specialty care where it's very siloed, and you get the world-leading expert in this one gene who then pioneers the therapy for this people who have this one sort of specific genetic abnormality. So we're already used to interdisciplinary care, so we try to see every patient as an individual, understand what the needs are, bring in other specialty care as necessary, and then provide very stable recommendations for what we call symptom titrated rehabilitation, meaning that the patient sets the pace, that we do not push into areas that would cause post-exertional symptom exacerbation or post-exertional malaise. We use medications as necessary in combination with rehab to enhance the results of rehab. So it's not just off you go to rehab. If you have autonomic dysfunction, you're getting blood pressure medications and heart rate medications that can stabilize you and allow you to tolerate rehab more appropriately.
Great, thank you. And then Nick, if you want to take it from here, we're ready to move on to the live Q&A.
All right, so let's see. One question from somebody, anonymous, says they wanted to ask Nick about the vaccine injury. Is there a possibility that you were infected and vaccinated at the same time, not knowing that you had asymptomatic infection and then vaccinated, or you never infected? So I was not infected. Ironically, I have COVID right now, but I have not had COVID up for these 2 years up until now. The reason that I did not equate it to COVID is for a few things. So before getting the vaccine, I actually went and got tested because they had said at the time not to get it if you had COVID. So I got tested. I never had it. I wasn't sick. Everything was normal. So I got the shot. And so I had some pain in the arm, but nothing weird. I went to sleep that night and I woke up to use the bathroom, and I had like a POTS syndrome. So my heart was all messed up. I couldn't breathe right. I almost fell over. Very strange. Never experienced anything like that. Went back to bed and it was gone. So I still had this arm pain, upper arm pain, but I didn't have any weird issues. I wasn't sick. And over the course of about 10 days, I started to lose access to my arm. And it literally spread from the vaccine injection location, eventually overtook the whole body. And it kind of turned into a very Guillain-Barré-like neurological disease. I never got sick. So it just went straight into like injected with neurological long COVID, which is very rarely talked about as a COVID symptom.
I would just sort of jump in with one thing, having seen some of the things popping up in the chat. Clearly Nick is sharing a personal experience. I also think we need to acknowledge just how many different mechanisms there are for how the vaccine and how COVID can cause the symptoms that they're causing within your body. So, I saw one of the comments flick up about orthostatic intolerance and hot baths absolutely, that is a really great point, that if you have dysautonomia, a hot bath is going to trigger some of your dysautonomia symptoms, because as the heat will increase your heart rate, and as your heart rate increases, you get clicked into a sympathetic event, and you can get, you know, a POTS flare, or just a dysautonomia flare. So, you know, with all of these things, I mean, we're right in the infancy right now. So, Nicholas, a bunch of things that I've heard many other people say experience relief. I've, you know, throwing magnesium salts into a hot bath as well, and, you know, things like that. But also with the understanding that if your specific constellation of symptoms are different, and it's, you know, if you've seen one long COVID or vaccine injured person, you've seen one long COVID or vaccine injured person. So understanding that we need to try these things in a way that you're kind of experimenting on yourself right now. If you know, dip the toe in the water first before dunking yourself in all regards, not just fixating on a bath. But yeah, I just wanted to say that there are lots of different things for, you know, and I saw infrared light, I saw hyperbaric oxygen. There are like reasonable data sets on all of these things that have been listed, and in some folks they really do give benefit. And so sometimes it's just about experimenting and trying things out. And as a, you know, on the treating side, on the clinical side, you know, we're cataloging all of these things, because if one thing doesn't work, we've got a list of 10 other things that we can try. You know, the biggest problem I see is that we don't have clinicians that are willing to try. And what I like to do is say, here, you know, when someone comes to our clinic, it's like, here's the first line of things that we're going to try, but don't worry, because if they don't work, we've got a second, third, fourth, fifth wave of things that we can try. And we're going to get there together. And so I think even in these communities, this is how we've got to approach it. What worked for me might not work for you, but don't worry, because there's 5 other people who have tried something else that worked for them, and let's just keep pushing through.
Very cautious what you're doing. It sucks because you want to be better and you want to just throw stuff at it, but you can make yourself worse trying to get to that better space. It's just better to be cautious going forward.
Dr. Putrino, someone's asking if you have any recommendations for specific exercises or treatments in general.
So that's we've got 8 minutes left, and I would say that is a whole universe of conversation. I mean, I would say that if you gave me one exercise that I could give to everybody that globally has helped the most people in my experience, it has certainly been adopting a breathwork practice that focuses on parasympathetic breathing and increasing levels of CO2 in the body. We have certainly seen that folks with long COVID have, and we have not yet replicated this in vaccine injury, but it's in our plans, but folks with long COVID have reduced levels of carbon dioxide in their body, which is called hypocapnia. We published on this, and, you know, it's out there as an objective finding. And when we gave people breathwork protocols that increased levels of carbon dioxide whilst following a parasympathetic breathing paradigm, which is really a slow inhale, a hold, and a long exhale. This practice being done, you know, for you know, short periods. It can be 2 or 3 minutes of this breathing, but scattered throughout the day, sometimes 10 or 15 times through the day. It seemed to, in many people, you know, a majority of people, it seemed to just reduce symptom burden. So like I said, there's a million things that I'd like to talk about, from autonomic rehab and vagus nerve stimulation and supplementation for, you know, mitochondrial function and so on and so forth. But if I had to stick to one, which I have to stick to one because we're running out of time, breathwork has been the lowest risk and the highest reward.
We have time for one more question. So Dr. Putrino, what is the percentage of the long haul recoveries have you seen at Mount Sinai long COVID since 2020? Do people get long COVID from Omicron? Do you see that numbers of people getting long COVID decreased in 2022?
I try to shy away from questions about numbers of folks with long COVID. Largely, this may be controversial. Who cares what the number is right now? I hope that the numbers, I hope that epidemiology comes out in the wash in 5 or 10 years. But right now, people need care, and we shouldn't be either minimizing the problem or maximizing the problem by trying to guess at what the numbers are right now. Because for a few reasons. First of all, it's so hard to know if the number of folks who are getting long COVID from Omicron or the number of folks who are getting vaccine injury from the bivalent booster versus the original vaccine are similar, the same, more or less, because most people don't know what's happening to their body at this stage. I mean, what never ceases to amaze me, despite this amazing community here and all of the activism online, there's still so many people that I, in the regular public, that I have a conversation with them and they've never heard of long COVID. It's just not really crossed their radar. And so a lot of people don't know what's happening to their body. And so we're not going to know about, many of the folks who are still coming to see me are finally getting a referral to the clinic after getting COVID in 2020. And, we're definitely getting a lot of folks with Omicron based long COVID. It's certainly a big percentage of folks coming to the clinic, but, we're not going to know what the true numbers are until much further down the track, when we're finally able to categorize everything. We're finally able to have providers using the ICD-10 codes correctly and appropriately, because right now, if you do an EHR review, and this is why I have an issue with all EHR data sets, whether they be non-minimizing long COVID or minimizing long COVID, the data are flawed because the majority of folks that get that ICD-10 code diagnosis are people who got severe acute disease, ended up in the ICU, and now have persistent issues. It's much less likely, proportionately less likely for you to get that ICD-10 code if you had less severe non-hospitalized illness and have gone on to develop long COVID symptoms, despite the fact that the majority of the estimated, 5% of the US population who may have long COVID, the majority did not have severe acute disease. They had mild or asymptomatic or less severe acute disease and went on to develop these symptoms. So right now, the numbers game, it's just a mess, and it's not, in my opinion, it's not worth dying on a hill over. It really, what we need to be saying is there is an enormous number of people who are suffering right now, and we need to treat them, and we need to be mindful of the fact that just like any other lifestyle disease, where 50 years ago we weren't diagnosing it, but bit by bit, 1% more of the population got it each year. This is what we need to be thinking about. This is what we need to be worrying about, is that there's a huge population of folks who have long COVID, but also with each wave, there's a few more and a few more and a few more. And we need to get practice in place and structure in place to care for these folks, not argue. I mean, arguing over whether or not it's a major priority, this is irrelevant. People are suffering. People need help. And like I said multiple times, unless you have an agenda, there's no doubting the science. The science is that this is an organic illness that is caused by pathobiology that is disrupted in the body. Whether or not we're talking about long COVID or vaccine injury, in both cases, we know for a fact that things are physiologically wrong from the science. And we need to just get to work on treating this population of folks who are not returning to their normal lives.
Thank you. I have chills. I couldn't agree more. And I know a lot of people feel very similarly. So we have one last question, and that is for Leslie. And the question is, are you doing any Paxlovid research for long COVID?
Yeah, I saw that come through, and it's a very timely question because we actually are helping to launch a Yale randomized clinical trial in a few weeks for those with long COVID. You need to be a member of Kindred to be considered for the trial. There are certainly a lot of inclusion/exclusion criteria that are going to be going through, but we actually are going to start a waiting list shortly for those that meet the criteria. So please, if you are not in Kindred, a member of Kindred, please join. This is just for those who are experiencing long COVID at this point. But, as you know, we are committed as well to more research for those with vaccine injury as well. But I did want to let people know that actually is in the hopper and is just getting final IRB approval. And I think, David, you also are going to help with some of that recruitment as well. So we're very, very excited to address that. And David, if you want to talk a little bit more about that, please do, because you're the scientist, I'm not.
No, I mean, yes, we're Mount Sinai is excited to be included in this. This is super exciting. I hope that this is the trial that launches 1,000 intervention trials in 2023, because that's what we need next, interventional trials.
So much for joining us today. This is another incredible Café. As always, reach out to us with any questions, comments, feedback. We are here for you. So you can contact me, Talia, at Hugo.health. And also, if you have a story that you would like to share, I know you've seen me sending out stories weekly in our Kindred emails, whether it's just, talking about your symptoms and disease progression, or something you've learned, something you've accomplished, or finding support, anything like that. I would love to share your story with the Kindred community. And you don't have to be a writer. I can ghostwrite for you. We can just do a Zoom interview, however you'd like to go about it, or you can do a video, poem, etc. So please reach out to me. That's Talia at Hugo.health.
And I'm gonna I hope I'm not misspeaking, David. Sometimes what we do, because there's so many questions we haven't gotten to, we try to do a follow-up, and we might send you a few more that you might be able to just do video responses to, or quicker than handwritten responses, and just to help, because there's so many questions that we didn't get to, and we apologize for that. So it's hard to fit everything in an hour, but appreciate everybody's engagement here.
No, absolutely, we'll do my best as well, and totally acknowledge that there were a lot of questions, and an hour is suddenly very, very short.
I know. Well, thank you, everyone. Be safe.
Bye.
Thanks, David. And
Thank you.
Cynthia and Nick. Bye.